All right, so let's, as we get our two eminent faculty settled in, we have a couple of questions. Dr. Kleiman, how many days before surgery do we stop antiplatelets?
First of all, it depends what kind of surgery we're talking about. So I had 2 wisdom teeth extracted last year. I told the oral surgeon, I said, I'm on Plavix. He said, so what? So he said, take it. So that's pretty clear. If you're having surgery that really predisposes you to bleeding, that you can't compress with a 4x4 or a tea bag, you probably do need to stop it. And it gets interesting. Ross will tell you should be off it for 1.5 years. The GI guys tell patients stay off it for 10 days. The real truth is if you look at platelet function studies that have been done serially after you stop clopidogrel, after about 3 or 4 days, you still have some antiplatelet activity left, but it's usually at a basal level that will support hemostasis. The recommendation is a week for major surgery. I think that's a little too conservative. I think somewhere between 4 and 5 days is what I usually tell patients.
And I typically tell patients to stop about 5 days before. I think the studies that were done very early when we first started operating on patients on clopidogrel really showed that we saw a lot of bleeding if we didn't wait 4 days. Now there are various levels of responders. I think when you do the bedside studies, sometimes patients are on their clopidogrel right to the time of surgery and they have a platelet function of 60%. Sometimes we get them in 5 days after stopping it and the platelet function is 9%. So, there's a variation in how they metabolize it. What I've done is I've asked them to stop the Plavix 5 days before surgery. When they come in, if it's totally elective surgery, when they come in, I check the platelet function test. If I'm doing an on-pump operation, I'd like the platelet function to be at least greater than 45% or so. But that kind of changes depending on the condition of the patient. If it's very low and it's elective, I will hold off on the operation and have them come back a few days later. But that's been the way I do it.
Great. We have actually two questions which are alluding to the same issue about minimally invasive bypass surgery. Dr. Reul, can you educate us more about that?
So a lot of what I've been talking about trying to make CABG great again had to do with long-term outcomes. We're talking about 20, 30-year outcomes. The reason we do bypass surgery is to try to give a patient an area of the heart that's getting blood flow for the next 20 to 30 years. Every single stitch is important. When you look at what stents do when they go inside an artery, the same thing happens when we cut and sew on an artery. There's an area of inflammation. The inflammation can result in scar healing in one way or another. And if you're very careful and everything is perfect, you may trick the biology into not bringing in all the platelets and monocytes and macrophages and things that create neointimal hyperplasia. So my feeling is that you can get away with minimally invasive bypass surgery. Some surgeons have had excellent results in early term. We don't have a whole lot of data for 20-year outcomes. I think that when you're doing a bypass operation, you really want to find the very best point on each target vessel, and a lot of that is really found on an open procedure.
Yeah, I don't know how to do a bypass operation. I've always wanted to try. So
Let's do it this weekend.
I don't tell Ross how to do the surgery, but I do know that I send a patient to Ross because he can do something with an anastomosis that I can't do with a catheter. And I always have to remind the surgeons that my incision is smaller than theirs, no matter how small they do it. So, as a guy who sends the patient, as a guy who gets the patient back, I don't care how big the scar is.
Okay.
And I've found that the so-called minimally invasive operations, when you do a thoracotomy incision between the ribs, it can hurt a lot more than a sternotomy incision does. And so I don't even call it minimally invasive. I call it different invasive cardiac surgery. But that's my interpretation. There are some surgeons who have had excellent results. But my feeling after doing minimally invasive bypass surgery and doing it open, I think that you really get the best anastomosis if you do it open.
We may have time for one or two more questions. These two guys are gentle giants, so please ask if you have any. But if there is none, I do want to ask both of this and help us out with the TAVR question, because Dr. Kleiman runs the TAVR program and Dr. Reul does them. So should TAVRs be used in patients younger than 60? Dr. Kleiman.
Well, we make a mistake in medicine, and this is part of, first step in the path. A guy comes to see me with high cholesterol, and he says, should I treat my cholesterol? And, if you think about it, you're not treating his cholesterol. You're interested in treating his risk. So the real first question you should ask when you're talking about treating anyone is, what's their risk of treatment? What's their risk without treatment? So look, the real truth is there are some patients who are less than 60 years old who, for a variety of reasons, are at elevated risk for open surgical valve replacement. For those patients, the answer is yes. Now, there are a couple of caveats. We don't really know a lot about TAVR in patients with bicuspid valves, which are more frequently seen in younger patients. And if a patient is less than 60, has a tricuspid valve, as 95% of people do, and is at low risk, we don't know the answer. There are 2 large randomized trials going on now that are designed to address that question. We'll have early results next year, but really it's longer term results. And so we don't know the answer to that question yet.
Okay.
The number one question that people have about TAVR is durability. We don't know yet. We have several of our trials were done earlier with highest risk patients that are out 10 years. We have some patients out 7, 8 years. The low risk clinical trials, we won't have those results. We won't have 10, 20-year data on those patients for 10 or 20 more years. So we don't know yet what the durability of this valve is going to be. When we look at the lab results, all the in vitro studies, when we look at the results we have to date, it seems to be comparable to the surgically inserted tissue valves. We know that the surgically inserted tissue valves have a longevity that's dependent on age when they're implanted, but it's also dependent on several other things, as Dr. Lowry told you. So I think these days, as we look at patients getting tissue valves, more and more younger patients are getting tissue valves surgically. We're implanting tissue valves in patients in their 50s and 60s, and several registries have shown us that the survival rate is similar in patients in their 50s to 60s getting a tissue valve. So I think we put all that together and we try to figure out, should we put a TAVR valve in a 60-year-old? At this point right now, off clinical trial, I can't justify that every 60-year-old should get a TAVR valve instead of an open surgical valve. But I can say that the choices of getting a tissue valve, the age criteria have decreased quite a bit over the last 10 years or so. And when you start looking at whether we can start saying, well, you get a TAVR now and then you get a surgical valve 10 years from now and things like that, it's, we get into areas where we're talking about things that we don't know about yet.
Okay.
Yeah, so I agree with that. I'm less concerned about durability because we can treat valves that deteriorate, and so far we don't see the signal. I'm more concerned about the fact that we leave often a little bit of aortic regurgitation behind when we do a TAVR. And in a patient who's in their 70s and who's got a 10, maybe 15-year horizon, that's one thing. In a patient who's 55 and who has a 20 to 25-year horizon, I don't really know what leaving them with a little bit of aortic regurgitation is going to do to their ventricle. That's what scares me more than anything else.
Or a pacemaker.
Or a pacemaker.
Fantastic. Well, thank you. Thank you both Dr. Kleiman and Dr. Reul so much for a fascinating session.